We're back.
I'm still here.
He's still here. It's like he never left. None of us ever left. We're all here, and this is the final roundup for Friday. We've got one day left tomorrow of the Wellness Week workshops, and today we're doing a roundtable. So Dr. O and myself will be answering some of the questions. Well, I mean, it's a question when a client or a patient comes in and says, "My doctor said," and then they ask us what we think. And I've got some favorites that we came up with, and some of them are directly geared into Dr. O's wheelhouse, and some I can't wait to take. And we'll see what else. Maybe we'll get some from the listeners. You can type them in the comments. If anybody here has any favorites that their doctor said, we'd be happy to address it. But it's a common thing when and Doc, we oftentimes get people coming into the wellness center that have exhausted those other means.
Yes.
And they kind of, give us that last chance.
Right.
So
they give us that last chance once they've exhausted all other means. And one of the conversations we have with each other in the back when nobody's listening in is, you came here looking for a miracle this big, and we got you one this big, and you're upset that this part wasn't fulfilled. You didn't come here first, did you?
No. It's very, I think every once in a while we get somebody come here first, but usually we don't.
Right.
Usually we don't. So let's dive right into a couple. Okay. Doc, I know you have a couple favorites. So what would you like to do first? How about, my doctor said my knees are bone on bone?
Well, because you came in, even if you're on crutches, I could buy that your x-rays are shadow on shadow. But if you're not wrapped in an ice pack with your leg fully extended and locked in a position, I'm skeptical. I'm highly skeptical that it's bone on bone. You look at somebody.
The pain would be off the chart, right?
It would be unbearable. If you look at somebody's x-ray, it's very easy to see the illusion of bone on bone because of how the shadows lie. But it's just, you walked in, it can't be the case. It's just physically impossible.
Yeah. All right, so what's our first course of action there?
Well, the first course of action is, of course, to take a history and figure out what's going on, how long has this been going on, what have you done for it up until this point, what have you done that made it feel better, what are you doing that makes it feel worse, and that gives us an indication of which muscles are involved, what other joints besides the knee is involved. In some cases, what can we realistically hope for? And we're going to examine this patient and figure out if our exam findings and our suspicions are aligned. And assuming that they are, and assuming that there are no big red flags, I think it's appropriate always to start with the muscles. And we're going to get tight muscles. I mean, you think about the mechanics of the knee, that it's a true hinge. Your femur bone is the bone of your thigh, and your tibia is the major bone of your shin. So which group of muscles are either preventing that hinge from happening the way it's supposed to, or which group of muscles are active, or which other group are inactive, allowing that hinge to behave like a spiral or to shear with one another. So the first move after we've determined that somebody's appropriate for treatment and there are no other giant underlying red flags and that we have a pretty realistic chance of doing them some good, is what are we going to do to make hinge happen and start to eliminate the shear and the spiral with a muscle perspective. And then if indicated, we're also going to we've looked at their hip, we're looking at their feet, and we're going to make adjustments possibly to the knee itself to reinforce hinge-like movement.
That explanation in and of itself speaks volumes, because undoubtedly they were at an orthopedic surgeon who said, you're bone on bone, you need surgery, right? Never talk to them about muscles, never talks to them about their hips, their gait, their weight, something, anything. But the key there, I think, is the relationship of the muscle to the joint. And that's where you go first. And and maybe the other ones aren't going there at all.
Yeah. Well, it's just an entirely different treatment paradigm. That, I mean, we talked about this ad nauseum on Tuesday and touched over it during the 11 o'clock hour today. And I'm interested in neuromusculoskeletal. You know, muscles are the skeletal refers to the skeleton. We got to talk about the condition, the connective tissue in between, how they all relate to each other. And we have to take the neuro into account possible. And we talk about the joints and how the joints open and close, or how they rotate with one another, or whatever action that particular joint does. And that joint's movement pattern is going to influence how the brain and that joint talk to each other. So what we're looking to do is increase the ranges of motion at a given joint, whether we're talking about the knee, it's allegedly bone on bone, or an ankle, or a spinal joint. We want to use all the tools at our disposal to work on that joint, to get it to move through its comprehensive range of motion, for one, to get it to stay that way as much as possible, for two. And the muscles play such a critical role in that, and they're just overlooked for whatever reason.
And then there's the nutritional component. Obviously, they're going to be very, very deficient in hyaluronic acid.
Sure.
And we need to address those things.
And minerals. And minerals. Probably have to do appropriate nutrients to dial down the inflammation. The nutrition plays a critical role. And when I see, I mean, I'm lucky. I work now with Dr. Ashley Rozzi, and I work with Jeffrey Niznik, and you're here quite a bit yourself. And I work with people who have such a comprehensive understanding of all the nutritional treatments and protocols. And like I do the basics. Like when I have my patients, we're gonna put a foundation in place, and we're gonna start to dial down the inflammation, and we're gonna start to increase the mineralization, which leads to muscle relaxation, and we're going to fortify the joint itself with some lubricants like hyaluronic acid. I like the HA plus. The plus is the glucosamine.
And the MSM plays a big part.
Right. Absolutely, you're absolutely right. And then I can, we start to make a little bit of progress, and the patient starts to get really enthusiastic, and then I can send them to you, or to Dr. Ashley, or to Jeff, and like, hey, let's somebody take this foundation that I help you put in place and run with it, and really do a good nutritional workup, and you and I will continue to do the mechanical treatments. But that's the strength of working with a team like this.
Right.
We share patients all the time.
I want to bring up a good point about bones too, and that is, since we've been doing so many Oligo scans lately, what I'm finding as a deficiency, even more so than calcium and magnesium, is phosphorus. And that's a huge component in bone health.
Yeah, you're absolutely right.
And I think it gets overlooked.
Yeah, you're absolutely right. That's a good point.
So we have the tools to really drill down on these issues, starting with the structure, starting with the musculature, and then, of course, adding in the nutritional component, right? Okay, so how about, my doctor said I need rotator cuff surgery?
Well, you might not. I mean,
you might not.
Pretty straightforward.
What do you do first?
Well, once again, it all begins,
because I know you've worked on lots of shoulders, including mine.
Well, once again, it all begins with a conversation, and let's make sure that what we're capable of doing for you here is a match and aligned with your expectations, and assuming we're going to be able to work together. The rotator cuff is a group of 4 muscles that act as the brakes. They're the brakes on the upper arm. So if I'm in the outfield and I'm playing right field, and somebody's going to try me and take that extra base, I'm going to whip my arm through space. How much does a baseball weigh? About a pound? But not even that. But work is weight times distance. So I'm extending my arm as far as I can with ultimate velocity. So all of a sudden, the length of my arm times the weight of the baseball. I mean, that's a lot of work to throw that ball. So why doesn't the way the shoulder is situated is it's a ball and socket, and the socket is relatively shallow. So why am I not dislocating my arm every time I throw the ball?
Right.
Or if I take my 16-ounce can of soup and I put it up on the top shelf in the cupboard and I'm reaching, I mean, it's the same mechanics.
Yeah.
Right.
Yeah.
So I have my rotator cuff, which is going to pull backwards and prevent me from wrenching my arm out of its socket. So the rotator cuff, when you think about the muscles that are involved in throwing, or the muscles that are involved in lifting that 16-ounce can of soup and putting it up in the cupboard, those are very big, strong, dense muscles. And the rotator cuff is relatively small, and it has a big load to carry compared to the prime mover muscles. So rotator cuff injuries are extremely, extremely common. I mean, I would go out on a limb and tell you most adults will have a rotator cuff injury at some point in their life.
Now, when they say it's torn,
right,
degree of
absolutely
tear all has
absolutely.
a lot to do with it, right?
Absolutely.
Right.
So if you give a muscle the appropriate rehabilitation, and that means the neuromusculoskeletal chiropractic and the trigger point muscle therapy work, and as it starts to recover, very targeted stretching and strengthening exercises in balance with each other. If you give it that, the muscle will fix itself. The muscles have these incredible self-repairing properties.
Right.
The rotator cuff itself are these 4 muscles that come together and form a common tendon. So tendons connect muscle to bone. So if the tear is a full thickness tear of the tendon, I'm sorry, we got to send those people for surgery. That's really the best option.
Okay.
But if that tendon is only partially torn, or if the tear is in the muscle belly, I think it's very, very premature to send somebody for, to say you need surgery. Because you got a list as long as the day is long of all the people who've had rotator cuff injuries that were not something less than a full thickness tear of the tendon to the rotator cuff that we've been able to help dramatically here.
And the key here is options.
Yeah,
right.
Absolutely.
Options. Because folks, no matter what, when you go to a surgeon, what does a surgeon do?
They do surgery.
They do surgery. Okay, that's all they do.
Right.
They're going to recommend it because that's their wheelhouse.
Right.
Okay, but we have options,
Right.
and we can help you with those things.
Right.
Great explanation.
Thank you.
Thanks, son.
Thank you.
I got one here I'm going to take. I mean, before we get to some of the obvious ones that we'll have some fun with, I hear this a lot. My doctor said iodine has nothing to do with my thyroid health. All right, just my thyroid panel. That's it. That's all that matters. Where's my T4? Well, I love when someone says that, because then we can get into just a tiny little bit of chemistry. Because when you get your thyroid panel done, your blood panel done for your hormones, there's a T4 and a T3. And we know those are thyroid hormones, right? But I ask them, do they know what the 4 and the 3 stand for in T4 and T3? Well, the answer is the 4 is how many iodine molecules are attached to the thyroid hormone. And the 3 represents 3 iodine molecules attached to the thyroid hormone. So for someone to say iodine has nothing to do with it, and it's right there in the definition of the hormone, we have a problem. So yes, iodine is important for thyroid health. Iodine is the #1 nutrient for thyroid health. Dr. David Bronstein is the world-renowned expert on this. We've read his books. We follow his recommendations. He says that the thyroid requires around 6 to 7 milligrams of iodine on a daily basis. 6 to 7 milligrams. Now, up until just a few years ago, Doc, most iodine supplements were in micrograms, right?
Yeah.
Yeah, the first one years ago was Iodorol.
I remember that well.
Remember that? Came in a tablet, hard tablet, 50 milligrams. I think one of the reasons they used 50 was because you weren't going to absorb it.
Yeah,
in that hard tablet,
sense.
But then we've been able to improve upon those formulations over the year, and that's why with Iodine Plus they come in 12.5 milligram capsules. Now the reason is you need about 6 or 7 milligrams of iodine for your thyroid gland to operate at an optimal basis on a daily basis. You also, and especially for women, you need about 6 to 7 additional milligrams of iodine for for optimal breast health. And today is October 1st.
It's a good day to bring this up.
Good day to bring it up. And I don't see anybody wearing pink, and I'm glad about that because we don't believe in that. We don't want awareness. We want action. Okay? We want action. We want causation. We want to get to the cause. We're not looking for a cure. We want to prevent it. That's another topic, and I'm not going to get on that soapbox. But iodine is important for breast health. So that's 6 or 7 for the thyroid, 6 or 7 for breast health alone. Well, you're up to 1 capsule of Iodine Plus right there. Right there. Okay? But I got more for you. Iodine is in every cell of your body. Yeah. Every cell of your body. Everybody needs it. And it used to be in our diet. Baked goods used to include iodine. Mm-hmm. Of course, that got too expensive, and they replaced it with not another nutrient, but a toxin, bromide. And there you go. We multiply the storm, and now we have the deficiencies and the disease states that follow them. So iodine is important. Now, the problem is you really don't do an iodine blood test.
No.
The only one available before was a urine test. But now the Eliga scan does show iodine. So if you want to know if your iodine levels are sufficient, come on in, make an appointment for an Eliga scan, and we'll let you know. Okay, how about, do you have any, Doc, before I go on?
Well, one that I can't say that I get this every day, but certainly every week, is a patient will tell me that their doctor said that their back is the worst he or she has ever seen. and all I can do is think to myself, your doctor really needs to see more backs if you think that. And the reason why I can say that so cavalierly is I couldn't help but notice you walked in under your own power. So I think that, chiropractors are guilty of this too. Physical therapists are guilty of this. I think there's a lot of sensationalism in healthcare, and you want to get our patients, like, we're going to have a big call to action and get you to subscribe to the services that we provide. If I were a patient and my orthopedist said to me, "Your back is the worst I've ever seen," I'm not going to dial myself down. Like, wait a minute, the worst you've ever seen? Are you kidding? I'm not in the wheelchair, right? You got to see. I'm thinking, oh my God, this guy's an expert, and this is the worst he's seen. And I think that's the natural response. And I feel like a part of my job is to just let's put things in context. Yeah. Let's dial this back a few steps, and we have to know where the panic button is at all times. That doesn't mean we need to reach for it at all times. We're not treating the panic button like it's the snooze button. So let's just stop and figure out what's going on here and ask ourselves the question: is this really as bad as it's being made out to?
Yeah. And why are they pushing that fear button so quick? The practitioners.
To create. I'm gonna sign you up for a long-term healthcare plan. I'm gonna get you make an impulse buy, and that impulse buy might be. I know of chiropractors who are signing people up. They're getting patients to pay in advance or pay in chunks for 50 visits over X number of month period. Are you kidding me? They're 52 weeks in a year. I can count on the fingers of my one hand the number of people I see 50 times a year, let alone over the course of a few months. I don't get it. I mean, that's a masterful sales technique.
Yes, it is.
And the orthopedist is hopefully, or the neurosurgeon, they're not selling 50 visits. They're selling one, and it's the big prize. It's spinal surgery.
Spinal surgery.
And let me plant the seed right now that this has to be done, and it has to be done soon, because this is the worst I've ever seen. I've been at this for years and years and decades, and you, sir, have the worst I've ever seen. And we're going to have to operate, and we're going to have to operate before you have a chance to
get another opinion.
Right. And that to me is a little bit more salesy and a little bit less.
I mean, surgery can always
it'll still be
an option.
Yeah, it's always an option.
Why not try something else that's not so drastic, invasive, and deteriorating? I mean, when we talk about damage, cellular damage, and tissue damage, free radical damage, all these things, surgery is an injury.
It absolutely is.
And
Absolutely.
I don't think people equate that quite the same way. If you get mugged and cut with a knife,
Uh-huh.
what's the difference between that and getting cut with a scalpel to your body?
Well,
To your mind, it
body,
might be different,
yeah,
but to
yeah,
your
yeah.
body, it's no difference.
Right, right.
This is traumatic. This is tissue damage at the highest level.
Yeah.
So all surgeries are extreme injuries and have to be
Yes.
treated that way.
Yes, yes. And I think about, some of the real wins that I've had with patients over the years. And I think about one that we don't really, this is a specific person, but we don't talk about this concept enough. And when this person came to see me initially, they were under the impression that they were going to have a total hip replacement. And we did, we did a treatment plan. I don't remember exactly how many treatments or how long it lasted, but by the time we were done, they still had surgery. They didn't have a total hip replacement. They had,
Okay.
I'm not sure, I'm not sure the names of all of these procedures, but it wasn't even a partial hip replacement. It was more of a, let's clean this up and
Right.
stitch the labrum is the form of tissue, the very well lubricated form of tissue that lives inside of the socket in the joint. So we can have smooth, easy gliding of the joint, of the partner bone in the joint.
Right.
And so this person had a labral tear that, there was nothing, for love or money, we weren't going to be able to fix that. That had to be stitched up.
Right.
But we went to from total hip replacement to labral patch job, and
that's a big win.
Right, it is. And surgery is surgery. Let's not make light of it.
Right.
But when you think about, are you going to spend months and months and months doing rehab, or are you going to spend weeks and weeks doing rehab?
Right. Yeah, big difference.
Yeah, very big difference.
And you're right. Surgery is surgery, no matter how small.
Yeah.
No matter how large.
Right.
But let's cover all the choices first, and let's minimize the amount of injury as possible.
Exactly.
I'm going to take one of my favorites. My doctor said my cholesterol is too high and I have to go on a statin. I was not going to let this go. My cholesterol is too high. We have to go on a statin. How high is your cholesterol? 200. 220. And that's too high. Really? Yeah. Well, my good cholesterol and my bad cholesterol are way off. Aha. I see. So let's cover that for a second. Number one, when they say your cholesterol is too high and they say the only option is to go on a drug, it's time to get a new doctor. Because it's not the only option. And first of all, it's treating it from the wrong perspective. Number one, it's the number. The number is not too high. That started, and I know doctors that have been in this industry longer than me, and they said that nobody got a statin drug under 300 total cholesterol when they first started. That switched to 250. That switched to 225, 200, and now I've heard 180 in some cases. Why? Because they ran out of customers. Okay, so using a drug to address a vital nutrient of the body and stop its production along with the other vital nutrient, CoQ10, is, to me, a major problem. You should find a new doctor. If they don't tell you, well, let's take a look at your diet and your lifestyle. Let's find out if you have some vitamin deficiencies. Maybe the cholesterol is forming plaque prematurely because you have some issues with trans fats and antioxidants. Maybe you're not processing it properly. Okay, that's the approach that we want to take. If it is over 300, if it's over that, there is a problem in the body. It's how the approach. The problem is that you're not processing it properly, not that you're making too much. And that's the way it's approached by the allopathic physician. So don't give in to that. Talk to someone here, talk to any naturopathic or functional medicine practitioner first. See if there are options. Statin drugs are debilitating. They are. How many times do you treat people for their legs and their knees and their hips, and the muscles are so deteriorated from statin drugs?
Yeah, not just their knees and hips, but I see a lot of people with really like they complain about lower back pain, and like I'm feeling what's going on with the musculature, the paravertebral, the two columns of muscle on either side of the spine, and it's not there. It's just where did this go? And then looking over their list of medications, and sure enough, they're on a cholesterol medication.
Of
So
course.
it's really a global systemic possibility of
It
problem.
is.
Yeah.
It's systemic.
Yeah, and once again, like we're not sitting here with an axe to grind with
No.
the medical people. We're not saying that drugs and surgery aren't necessary.
There are times.
We're just saying that like there are other things that can be done a whole lot sooner. And back to the question we've always asked ourselves since day one: what do we do to keep healthy people healthy? And just because you have elevated cholesterol doesn't mean you're unhealthy. It might mean you need some help. It might mean it's time to call to action, but you could still be very fundamentally healthy. And with a few lifestyle tweaks or addition of a certain nutritional supplement, or maybe an elimination of something, and all of a sudden, our healthy people are healthy again.
Yeah, it's the same thing with that, with blood pressure. See people come in all the time. What do you have for my blood pressure? And they're 50, 60, 70 pounds overweight.
Right.
Oh, my blood sugar is high, and they have a 60 circumference waistline.
Yeah.
And we want to be helpful, but it's got to be a lifestyle approach.
Exactly.
We can't. This isn't a green pill for an ill.
No.
And that's, I think, sometimes people get caught in that trap too. Right.
Absolutely.
Let's take the big one, Doc. Okay. We'll take this one together.
Okay.
My doctor said, "You're just getting old. That's normal."
Well, I think that's normal. I mean, I'm getting older, aren't you?
Yeah.
Let me pose this to the crowd. I mean, is there any one of us not getting older?
We're all getting older. Okay. But of course, maybe it's a matter of semantics, because my thought is this: we all have to age.
Yes.
We don't have to get old.
Right.
Prematurely, anyway.
Right.
Yeah. And I think that's the problem. It's the premature aging. That whole term anti-aging, we used to use it forever, in this industry. And we kind of got, called on the carpet for that. You can't stop aging. Okay, you're right. We can't. Right. But it's more age management.
Okay. That's
right. Age management, not anti-aging. And it's not that this is normal. Okay. It's not, you shouldn't feel tired and old, in your 60s. You shouldn't. I mean, some people are feeling that way a lot earlier than that, right? In the 30s. I've talked to a lot of physicians that do work specifically with hormones. They're seeing men in their 20s with testosterone, in the basement.
How does that happen?
Diet, lifestyle. Yeah. I mean, soy products. I don't know. Soy's in everything.
Yeah.
But yes, hormones are a vital part of aging well. Right. HRT business they've made a fortune on that. And we there's bioidentical hormone replacement therapy. I don't like to call it replacement. I like to call it hormone optimization.
Yeah.
Okay.
Yeah, well said.
Well, because that's what you can still stimulate your body to do these things. And then the physical part of it, Doc, they're not taking care of themselves physically. They're not getting adjusted on a regular basis, taking care of the structure, the spine that houses the central nervous system. Okay. The muscles that surround every joint in your body. I mean, that in and of itself, I think if they come away from this thinking, well, maybe it's not just my knee. Maybe it's the muscles. Yeah. Maybe it's my thigh. Maybe it's my gait. Have you noticed during this roundtable, I keep straightening up because I'm sitting next to Dr. O, and I'm making sure that my posture is good and correct. Okay. This is influence. And that's what you need. You need to be in an atmosphere like this and get influenced. Right. And that's what we can help you.
Right. That's so true. And I have so many friends and people I train with and people I went to school with, and even some people who I've helped to train who excellent chiropractors, and they're solo practitioners. They have like a 300 square foot office, 400 square foot office. Maybe they deal with insurance. Maybe they have a fee for service, that whatever it is. But it's like it's them, and maybe there's a one part-time employee helping run the front desk. And my crew of people, the people who I network with, they're good. I mean, these are people who can flat out, straight up adjust. These are people who they know how to examine a patient. They know how to find what they're looking for, and if they're going to be caught by a surprise, they're going to know what to do with it. I'm thinking of some really, really good chiropractors, and they're just like, I don't love it anymore, and part of that is just, you're in this
Burned
little
out. They're burned,
They're burned out, and part of it is they're just not in an environment full of people who are just looking at things the same way,
Right.
and like, I'm thinking like I'm kind of in the mood for a slice of pizza. I am. I see Jeffrey Nisnik walk by, and it's like, you know what? I'll just stay in the mood for a slice of pizza, but not necessarily eat it.
Yeah.
Right. So having that team of people and that group of people that, like, whether
Ashley Rossi,
right?
you can see her walk
Yeah,
by.
she's the picture of good health.
Picture of health.
Like you have a clientele of people. I mean, we have people, like we talked about this before the presentations. Are we going to wear masks for this, or what are we going to do? And like, I'm sitting here next to Joe. We've been working together, and we constantly report to each other who we're in contact with. There's nobody within 15 feet of us, right? But you look 15, 20 feet away, there's some really, really healthy people walking around, and they have questions about, well, what should I be taking this? Am I taking enough of that? Can you suggest that I do something else? Am I doing enough? How would you handle this? And it's motivating. It's inspirational, and that's part of the appeal of being here and having live workshops and open house sales, and having with the rebuild, our waiting room looks more like a coffee shop than a waiting room, and just being here, being around people who have a similar interest, and it makes so much sense, and it works out so well. Yeah,
it's beautiful.
Yeah.
Well, we're going to wrap this up. I know Doc's got to get back out there. He's got some patients coming up, and
I very much do.
I think this was fun. I think what we'll do is we'll keep this topic for the next one when we do a roundtable, and maybe encourage people to start sending in their my doctor said questions, and we'll address them at every Wellness Week. Okay, well, that's it for today, folks. I hope you enjoyed all of the workshops and the lectures today. They were our home team here, so and it was fun to bring Dr. Weiner back for from the dead. That was fun. Yeah, why not, right? He's the icon. This is named after him. But tomorrow we're back with another group of great workshops. Make sure you tune in tomorrow at 8:30. We'll recap today and we'll preview tomorrow for you. Till then, live long.